We're very grateful to all of you for being here on time this morning, but let us wait a couple more minutes so that we can have other colleagues joining the webinar. Thank you very much.
Otra vez, muy buenos días a todos y todas que
Once
están
again,
acompañándonos
thank you everyone
el
for
día de
being
hoy.
with
Les
us today,
agradecemos
for joining us for
muchísimo.
this webinar. We're very
Estamos
grateful.
esperando unos
We
minutos
are
para que
just
se
waiting a
conecten
couple more minutes
mis
so
otros
that we can
colegas
have all the
que
other
son
colleagues joining us this
nuestros
morning,
inscritos
at least those who
en
had
el día
signed
de
up
hoy.
for the
Entonces les
webinar.
agradecemos su
So we're
puntualidad
very grateful
y
for being here
esperamos
on
unos
time, and
minutitos
let us
más de
just wait a
atención.
couple more minutes. Thank you.
Bueno, muy buenos días, muy bienvenidos
Very good
todos
morning,
a
everyone.
este
Welcome
webinar
to this webinar
sobre las coberturas de
on
vacunación
vaccination
metabólica para el
coverage
año
in the region of the
2025,
Americas for
la situación
2025,
actual, los avances
the
y
current
desafíos.
status of progress and challenges.
Queremos
We
agradecerles a
would
todos
like to
estar
thank
aquí
each
con
and every one
nosotros
of you
hoy
for being with us
para
this morning
que entre todos
so that
podamos
all
conocer cuál
together
es
we
la
can
situación actual de
learn
las
about what
coberturas
the
de
current
inmunización
status
en
is
la
in
región de
immunization and
Latinoamérica,
vaccination coverage in the
entender
Americas,
entre nosotros
and
cuáles
to
han sido
learn
las
from each
experiencias
other
exitosas
about the
que
successful
algunos países han
experiences
tenido
that some countries
para
have had
seguir
in this
identificando a
region
los
to
niños no
continue
vacunados, niños
identifying
subvacunados
the
y poder
unvaccinated,
ponerles a
undervaccinated
todos
children, and to be
oportunamente y al
able
día.
to
Y algo muy
update their
importante,
vaccination
que ustedes
schedules.
puedan
And something very important
identificar
is for you to be
y
able to
verificar por ustedes
identify
mismos
and
la
to see for
información que
yourselves the
ustedes
information
comparten
so that
a
you can check
través
the information that you share with
sus
us
ministerios de salud
through
para
your
que
ministries of health
puedan observar cómo
so
esta
that you
información
can
es
see
transformada
how the
en
information is
análisis para la
transformed
toma de
into
decisiones y
analysis
para
for
que
decision
todos,
making,
entre todos,
and so that
podamos
all of us
tomar
together
acciones para corregir
can take
el
actions in
rumbo que
order to
estamos
correct
teniendo.
the path that we're
En
following.
la reunión de hoy vamos a tener,
In
como
today's
ustedes
meeting,
saben,
we will have,
todas las
as you
palabras de
know, first of all,
bienvenida.
we will have some
Luego, los
welcoming
colegas de la
remarks,
OMS
and then
van a
our colleagues
presentar
from
la
WHO
situación del
will be
WENIC.
introducing the
Todos
WENIC
sabemos qué es el WENIC,
situation. Many of us
las
already know
coberturas de
what WENIC
vacunación.
is,
Y luego vamos a
and
presentar cuál es el
then we will
panorama
be
actual de las
presenting the
coberturas.
regional
Vamos a tener
coverage
dos
of
experiencias de país
vaccination. We
y
will
luego
have
vamos a
two
tener la
country
sección de
experiences, and
preguntas y
then we will have a
respuestas.
Q&A session.
Entonces, pues los
So
invitamos a
we
todos
invite you
a
all.
que estén
You all know
súper
what WENIC
atentos
is, estimates of
para
national
poder
immunization
participar
coverage. We
públicamente en
hope that you will all
Para
follow
empezar,
this closely
quisiera
so that we can all
ceder
participate in this webinar.
el micrófono
And first of all, I'd
al
like
doctor
to
Hugo
give the
Rasuri,
floor to Dr.
Dr.
Hugo
Hugo
Rasuri,
del Programa Especial
who
de
is the Deputy
Immunización
Manager in
de
the
la
Special
OPS.
Comprehensive Immunization Program of
Gracias, doctor Rasuri.
WHO PAHO. Thank you, Dr. Rasuri. You have the floor.
Muchas gracias, Marta,
Thank
y
you very
buenos
much,
días a
Marta,
todas
and
y
good
todos los
morning
presentes.
to all those of you
Quisiera en
participating
primer
today.
lugar darles
First of all,
nombre del doctor
on
Daniel
behalf
Salas,
of
jefe
Dr. Daniel
ejecutivo del
Salas,
Programa
the
Especial de
Executive
Inmunización
Manager
Integral,
of
la más
the
cordial bienvenida
Comprehensive
a,
Immunization Special Program,
a este
I
webinar
would like
ejemplar,
to
que se
extend the most
titula Cobertura de
cordial
Vacunación en las
welcome
Américas
to this
2025,
webinar, Vaccination
Situación
Coverage in the
Actual,
Americas
Avances y
2025, Current
Desafíos.
Status, Progress, and
Quisiera
Challenges.
agradecer especialmente
I
la
would like
presencia
to
de los
address my special
responsables de
gratitude
los
to the
programas
presence of
ampliados de
those
inmunización de
responsible
los
for
países y territorios de la
enhanced
región,
immunization
de los responsables de
programs
vigilancia de
in
las
the countries in the
enfermedades
region,
inmunopreventibles,
surveillance of
de los
immunopreventable
encargados o
diseases.
coordinadores del
Those are responsible for
JRDF,
filling up
de
the
nuestros asesores de
HARR,
inmunización y
the
nuestros equipos
immunization
de
advisors,
inmunización
and our
en las
immunization
oficinas de
teams
país, las
in country
OPS,
offices
y de
in
los
PAHO,
colegas de las
those who
diferentes
fill out the
organizaciones que
information
nos
into the
acompañan hoy.
JRF, and the
También
representatives
quisiera
from
agradecer
different
especialmente la
organizations with
presencia
us
de
today.
nuestros
I would
colegas de la
like to thank the
Organización
presence
Mundial
of
de la
our
Salud,
colleagues from the World
también
Health
nuestros colegas
Organization,
de UNICEF
also our
y
colleagues
otros
from
organismos.
UNICEF and other partners.
Me parece muy importante
I believe that it is
resaltar
extremely important to
y
highlight
reconocer
and to
especialmente a las personas y las
acknowledge,
instituciones
especially
que
the
van a
people in the
compartir sus experiencias
institutions
el
that
día
will
de
be
hoy.
sharing their
Como lo
experiences with
dije,
us
vamos a
today.
tener, y
As
como
I
lo
said
mencionó
previously,
Marta
and as
también,
was
vamos a
mentioned by
tener
Marta,
la
we
presentación de
will
la
have a
OMS
presentation
sobre las
by
estimaciones
WHO
mundiales
on
de cobertura
the
hechas por la
global
OMS y
estimates
UNICEF.
of national
Vamos a
immunization
escuchar a
coverage
nuestra colega
done
de la
by
OPS
WHO
dando
UNICEF.
una
We will hear our colleague
detalle de las
from
coberturas
PAHO to
oficiales
give
de
us a
nuestra
detailed
región
information about
y
the
vamos a
uh,
conocer experiencias de dos
statistics
países,
in our
Brasil
region, and
y
we will
Paraguay,
hear about two countries,
conociendo las
Brazil and
lecciones
Paraguay,
aprendidas y las
knowing
estrategias que
about
ellos
the
han
lessons
implementado.
learned and the strategies that they have
Este webinar
implemented in Brazil
llega en
and
un momento
Paraguay. This
particularmente
webinar is taking
importante
place
en el
in a
año para
unique
todos y para
moment
todos los programas de
for us
inmunización.
and
Es
for
el
all
momento
immunization
en
programs.
que una vez
It is at the
terminado y
time in
consolidado
which
todo ese
once
esfuerzo de
we've
recoger los datos de
consolidated this
inmunización del año
effort in
anterior,
collecting the
podemos
immunization
sentarnos
data
a
for
ver
the previous year, we can sit
efectivamente
down and
dónde estamos,
collectively
a
take a look
reconocer
at
los
where we
avances
stand, to
logrados
acknowledge the
y
progress
identificar las
achieved,
brechas que
to
persisten
identify
y
the gaps that
fundamentalmente
still
tener una
persist, and
reflexión
essentially
sobre qué
to
debemos hacer
ponder
para
upon what
corregirlo.
is it to be done in order to
Sabemos que las
close those
coberturas son
gaps.
mucho
We
más que
know that
estadísticas, son un
vaccination coverage is
ejemplo
much more than
del
figures. It is an
acceso
example
efectivo de
of
nuestras
the real
poblaciones a
access
las
of our
vacunas, pero
populations
también a los
to
servicios de
vaccines,
salud,
but also to
la
health
capacidad de
services,
nuestros programas
the
para llegar a
capacity of our
cada
programs in
comunidad
order to reach
y en última
all
instancia nuestra
communities, and
capacidad para
ultimately our
proteger
capacity in
personas
order to
frente
protect
a
people
enfermedades,
and to
brotes,
prevent diseases,
complicaciones y
outbreaks,
muertes evitables.
complications, and avoidable
Y es
deaths.
precisamente por
And it
esa
is
razón que
precisely
el
because of
análisis de
that
los
reason
datos
that the
debe
analysis of the
transformarse
data
en
ought
acción.
to be
Debemos seguir
transformed or translated
fortaleciendo
into action. We ought to
sistemáticamente las
continue
estrategias y las
systematically
metodologías
strengthening
que
strategies and
sabemos que
methodologies
funcionan.
that we know
Tal, por
work,
ejemplo,
to delve
en
deeper,
el
for
despliegue
example,
de la
into the deployment of
microplanificación
a
y la
micro-planning,
planificación correcta
that
de
is
los
to say, the
programas de
correct
inmunización,
planning of immunization
fortalecer la
programs,
vigilancia
to strengthen
epidemiológica y
epidemiological
laboratorio,
surveillance and laboratory
mejorar
surveillance,
la
to
calidad,
improve
oportunidad
the
y
quality,
utilización de la
timeliness,
información.
and use of
Por
the
ejemplo,
information.
continuando
For
con el
example,
despliegue y
continuing
consolidación
with the
y el uso de la
deployment,
información
consolidation, and the
de
use
los
of
registros
information
nacionales
of
electrónicos de vacunación.
electronic vaccination immunization
Estoy
records.
seguro que el intercambio
I
de
am
hoy,
certain
las
that
experiencias de los
today's
países y las
exchanges
contribuciones de
and
nuestros
the
colegas
experiences of the
nos van a
countries and the
ayudar
contributions
en
by our
esta tarea.
colleagues will
Y
assist us in this
nuevamente
endeavor.
quiero agradecer
And
a
once again,
todos
I'd like to
por
thank all of
acompañarnos,
you for
muy
being with us this
especialmente
morning,
los que han
and
preparado las
most especially to
presentaciones,
those
y
who've
les deseo una
prepared these
excelente
presentations.
sesión.
And I
Y
wish
con
you an
esto
excellent
vamos
session.
a
And
dar
with
inicio
this,
a
let
este
us
webinar.
get the webinar going. Thank you.
Muchísimas gracias, doctor
Thank you
Rasuri.
very much,
Recordarles a
Dr.
todos que
Rasuri. I'd
este
like
webinar
to
cuenta
remind you
con
that we
interpretación
have
simultánea.
interpretation, simultaneous
Tenemos
interpretation for
interpretación
this
en
meeting.
francés,
We have
alemán,
interpretation into
portugués,
French, into
inglés,
English,
cuando las
Portuguese,
sesiones
and
sean
into
en
Spanish
español.
when the sessions are
Por
held in
favor,
Spanish.
vayan al
So
panel
please
interpretación
go
y
to the
allí
interpretation
seleccione
globe
el
at the bottom of the
idioma
screen, and you can
en el
select
cual
the
desee
language
escuchar
of your
la
choice, the
interpretación.
language in which you want to follow follow the interpretation. We would like to express our gratitude, as Dr. Rasuri was saying, for the presence of all our partners, including UNICEF and obviously the World Health Organization with us this morning. And so I now give the floor to our colleagues so that they can tell us about the results of the estimates of national immunization coverage, that is to say, WENIC for 2025. Colleagues, please go ahead.
Good morning, everyone. I will just stop 1 minute to leave people the opportunity to change the channel to Spanish or whichever. Good morning, everyone. My name is Laure Dumollard. I work at the World Health Organization, as Martha mentioned. And together with my colleague, Johan Nedelec, I'm going to give you an update on the WHO UNICEF estimates of national immunization coverage, so well known also as the VUNIC. And then we will pass on the floor to my colleague Paul Bloom for him to give you an update on the HPV estimates. For the VUNIC to start with, we're going to walk you through processes and methods very rapidly so that we can deep dive on the 2025 results, which I'm expecting are the ones that you are waiting for the most. On July 15, like every year, WHO and UNICEF published a summary on progress and challenges with achieving universal immunization coverage. A working group from WHO and UNICEF members, among which some of my UNICEF colleagues are with us, are meeting everywhere to produce the VUNIC estimates, based on which those summaries are published. The VUNIC are produced on a base of rules, which are mainly to triangulate data for 15 childhood vaccine doses for a single year cohort for routine immunization. In other words, it does not include catch-up doses. And for all WHO member states, plus Palestine, which is a UNICEF program country. Prior to publishing or releasing those estimates, the working group is conducting a country consultation. So all member states were given a chance to provide feedback on the draft estimates before they get released on the 15th of July. And on 15th of July this year, for example, we didn't only publish the 2025 data, we revised the whole time series so that whenever new data for previous years, for example, from coverage survey results, are available, they are included in the VUNIC. And therefore, this year, we produced the estimates with trends from 1980 through 2025, because each year is produced from 1980 to the previous year. With the exception of some newer vaccine, you will see a bit later, for which estimates are starting later, because obviously these are newer vaccines. So I mentioned this rule-based data triangulation exercise, and I have to say it follows really a methodology that was developed incrementally for the past 26 years when this exercise started. And this methodology has been reviewed several times by independent advisory bodies to WHO and UNICEF, such as Quiver or IVRAC. So I mentioned it's a rule-based system. What do we do within the VUNIC working group? Well, we look at the country-reported data within the EGRF, and we triangulate this data with national household surveys from that same country, and add also contextual information. Most of the time, this contextual information is coming from the GRF. And we just run the rules, except if for a reason or another, the working group has to ponderate the rules that are running because of some underlying information. For example, some contextual information, or we had a lot to do it during the pandemic. And that's how the VUNIC estimates are generated. They're generated with a PDF and are published on the web so that you can access all the information on the rule-based, but also on the working group decisions. Doing so, we recognize that this has strengths, but also limitations. The strengths are that the estimates are made using your data reported in the EGRF, and that on your data, we add the programmatic contextual information that you are also providing to us through the EGRF. And another strength we believe in these estimates is that we are applying a so-called grade of confidence, which is actually telling us how confident we are on the estimates that we are producing. It is not a judgment of the country's data, but on the estimates that we are producing. But there are also some limitations. The limitations is by definition, what I just mentioned, is that these estimates might be affected by the quality of the underlying data, the data that is reported in the EGRF. Another limitation is that there is no quantitative estimation of uncertainty. The VUNIC do not come with confidence intervals because of its methodology. Another one, which is not mentioned here that I should stress, is that here I recognize the name of participants that are from non-WHO member states, and so far, no VUNIC estimates are generated for non-WHO and UNICEF member states. And last, another limitation is that for most recent year, the estimates are informed by less data than for previous years. And we think the estimates are more robust for the past than for the more nearer years. With this, I'm going to give the floor to my colleague Johan, because he's going to deep dive on what you want, meaning the results of this year exercise.
Thank you, Laure. So yes, I'm going to present to you the 2025 VUNIC results. So firstly, let's start with DTP, diphtheria tetanus pertussis vaccine. So this slide is at global level, not only the region of the Americas, but I will focus on the Americas just after. On this graph, the line in the chart shows the coverage of DTP from 2000 to 2025. In 2019, global coverage was 91% for DTP1 and 86% for the third dose of DTP. It fell during the pandemic and has made a gradual recovery, but is plateauing over the last 4 years with a very small improvement in the most recent year. And on this graph, the bar shows the number of zero-dose children in blue, meaning that the children that did not receive DTP1 vaccine, and the gray bar is the number of under-vaccinated children, meaning those who have dropped out between the first and third dose of DTP. There is a general decline in the number of zero-dose and under-vaccinated children since 2000, up until the start of the pandemic. And then you see an increase in the zero-dose children and under-vaccinated during the pandemic, and then some recovery post-pandemic with some ongoing decline in the last 3 years. But we are still not fully back to the 2019 baseline. We were at 12.8 million zero-dose children in 2019, and in 2025, we are still above with 13.5. It's better than 2024. We were at 14.2, so we are making progress, but more work remains to be done. Here, it's the same slide, but focused on the region of the Americas. So coverage in 2025 in the Americas for DTP1 is 92% and 86% for DTP3. So it has improved compared to 2019 from 89 and 84 for DTP1 and 3. And among the total 13.5 zero-dose children, only 1.1 million are in countries of the Americas. And it has also declined compared to 2019 when it was 1.8. But you can also see that in the early 2000s, the number of zero-dose children in the Americas was only 300 to 500,000. So now on this slide, it's disaggregated by WHO region. It's the left chart shows the DTP coverage over time, and the right chart, it's the same data, but as percentage point difference from the 2019 baseline. And at the bottom, the bars show the number of unvaccinated children for DTP3 by WHO region as well. The region of the Americas, or AMRO, is shown in orange on this slide. So coverage in the Americas has been backsliding. It was above 90% between 2000 and 2015. It has declined between 2017 and until the end of the pandemic. And however, since the end of the pandemic, there has been a big improvement driven by large countries like Brazil and Mexico, and the coverage has improved above the 2019 baseline. It was 86% in 25, and it was 84 in 2019. Okay, up to now, I was showing you global and regional pictures. So let's deep dive on at country level. So on this graph, you see the DTP3 coverage for all countries in the America. In green, the green dot corresponds to the coverage, DTP3 coverage in 2025. The blue dot, the coverage in 24. The orange during the 2019 baseline. And the gray diamond corresponds to the 2010 coverage level. And the gray range, the gray bar that you can see, correspond to the minimum and the maximum coverage reached between the 2019 to 2025 period. So each country has been classified based on the following scenario. Declined are the countries for which 2025 coverage is the lowest point of the 2019-2025 range. So it's the case only for Honduras, Guatemala, and Bolivia. Partially recovered are the countries for which 2025 coverage is still lower than 2019, but it's not the lowest value of the 2019-25 period. Strengthened are the countries for which 2025 coverage is better than 2019. Those countries have fully recovered to pre-pandemic level and even improved compared to 2019. And the high and stable categories is for all the countries with the DTP3 coverage above 90% since at least 2019. So you can see that in the Americas, most countries have partially or fully recovered to pre-pandemic level. However, in many of them, we can see that 2025 level coverage is still lower than the 2010 coverage. Now on this heat map, it represents the coverage estimate for all antigens in the region of the Americas since 2000. For some antigen, for most of them, estimates are produced from 2000, but for some other, unique estimates were produced later, like for PCV, Rota, IPV, and also HPV. As I was saying, we see some decline between 2017 and 2021. But in 2015, coverage was of 90% or above for 6 antigen, and it is only the case for 2 antigen in 2025. On the good side, we see that in the past few years, coverage has increased. For all antigens, the 2025 coverage is higher than 2019. Now, let's zoom in on the 2025 picture. In these charts, we wanted to distinguish the unvaccinated children in two categories. The introduction gap is children not vaccinated because they live in countries where vaccine is not introduced. And coverage gaps is children living in countries where the vaccine is introduced, but they have not been reached by the program. So on this graph, each bar represents the total cohort for each antigen. So for BCG, it's the number of live births in countries that recommends BCG. Hep birth dose is the total live births in the region of the Americas. For most of the other, it's the number of surviving infants, except for MCV2, where cohort represents children of the minimum age at which MCV2 is recommended. HPV, it's 15 years old girls, and yellow fevers, it only includes countries at risk for yellow fever. So in green, you can see the proportion of children that were vaccinated. In red, it's the proportion of unvaccinated children because of introduction gap. And in gray, it's the proportion of unvaccinated children because of coverage gap. So in the Americas, very few introduction gap in 2025. The biggest ones are Hep B, birth dose, and HPV, with 8% and 5% of each cohort living in countries that did not introduce. The main proportion of unvaccinated children live in countries that have introduced, which suggests that improvements need to be made in program performance to increase regional coverage. Here, it's the breadth of protection. It's an indicator we use to assess the overall protection against 11 vaccine-preventable diseases. We combine the coverage of all vaccines to estimate the breadth of protection. So this chart shows you the evolution of the breadth of protection in Americas from 2000, when it was 51%, up to 83% in 2025. It has increased as a result of improvement in introduction of new vaccine, because you saw in my previous slide that there are very few introduction gaps that are remaining in 2025 in the Americas. So now enhancing the breadth of protection further depends on improving coverage in HPV, Rota, and PCV and MCV2, which all have a coverage of 80% or lower. And if you're interested, we have plenty of resources available for you. The links are on the slide here. It includes the data set for the VUNIC and the HPV estimate. We have multiple slide decks at country level or regional specific, and we have interactive tools, country profiles, and analytics dashboard that you can use. And with that, I'm going to give the floor to my colleague Paul, that will present the methods and the results more focused on HPV. Paul, over to you.
Thank you very much, Johan.
I let you share.
Yes, thank you. I'm trying to share. Here we go. It's my pleasure to be with you all. I'm Paul Bloom. I'm responsible for HPV vaccines. And let's continue with the estimates on HPV vaccine. Like my colleagues have done, I want to say some words about methodology, and particularly the fact that, you know, HPV, and I don't need to remind you, has a shorter history also in data collection. So this is a data set with a different kind of quality as UNIC, but there are many similarities and there are some specificities linked to HPV. And I think one of the things I want to focus on that we are having, and we're working towards, an increased alignment and integration with the overall UNIC, both methodology and processes. So you saw today earlier presented how UNIC works and what kind of information we're using, the context, surveys, and your reported data from your admin systems, the rule sets, and the way the working group works to come to the estimates. And for HPV, it's actually very much the same. We have a working group that uses the same 3 types of information. It's a specific separate working group for now, and it develops a set that looks like the UNIC set, but we have until now labeled that as slightly different as the HPV estimates, also done together with UNICEF as the HPV WHO UNICEF estimates. One of the differences is that we've started this work very much based on the admin data that was reported, mainly because very limited survey data on HPV are available. I showed an arrow going up because we are seeing more survey data points, and that will have important implications, particularly for the quality and the confidence in the data, as Laura was referring to. Contextual information, understanding what the programs do for HPV vaccines may be even more important, because there's a lot of shifting in ages, in groups that are being reached, etc., that have implications for the estimates. One of the other issues is that we have two key types of indicators. One is the program indicator, which is really an indicator of the short-term performance, and it tells you what's the coverage in a specific calendar year, what the program has achieved to vaccinate. We also have another indicator, which is coverage by 15, and this looks at a specific cohort after the primary target age of vaccination, which, as you know, is 9 to 14. And it tries to accumulate all the information we got from previous years about doses given to girls at any age, be it 9, 10, 11, 12, up to 14, to see what the resulting protection is at age 15. And we'll see a couple of examples of how that plays out. So for example, today I'll be drawing a lot on Mexico, and you see some of the program information from the country. You see here what happened with the program coverage in females over time in the country. And you can see that there was a bajón, there's a really a moment of challenge that started with a supply problems in 2019 and was exacerbated by the school closures and the COVID disruptions, and so strongly affected what happened in the calendar year with the HPV vaccination. And the other indicator, which is the longer term indicator, shows the following pictures. And you may see that the girls are being vaccinated between 9 and 11, more or less, and they should, the ones who did not receive vaccines in 2020, 2021, should by now, by 2015, have reached, by 2025, have reached the 15 of age. So you would expect to see something negative happening in that indicator as well. Actually, it is not. And the reason is that Mexico was reporting to us the catch-up they were doing in older girls, 12, 13, during several years. And this has then been fed into the coverage by 15, as I explained, and therefore we see that overall the protection of the girls by 15 in Mexico has remained high and strong. So this is an example of why we use these two indicators and what information they can give. One of the other very important difference is the way we calculate the coverage. One of the issues is that rather than dealing with a single type of cohort, always the same, like we have with UNIC when we look at the 0 to 12-year-old children. Here we look at girls that can be 10, 11, 12, 13, or 14, wider groups, etc. So we have different ways of measuring. Normally, the default is that we use, the direct numerators and denominators for a single age cohort, for example, the 10-year-olds. But often we deal with multiple age cohorts. And when that's the case, we sometimes have to use a MEC type of analysis, which means we use multiple cohorts as denominator, and the numerators are also drawn from the various doses across various ages. What often happens is when these catch-up MACs are done in the first year, then in the year after the introduction, countries continue doing that, and they continue vaccinating to wider age groups. So we need to start applying a kind of correction of those who are already vaccinated in a previous year but remain eligible. So that is a kind of a correction that we sometimes have to do. We see in some countries of the region, and Brazil is an example, where they end up choosing that all the girls and sometimes boys can remain eligible between a wider age range, 9 to 14. In that case, we have a different way of calculating the coverage. And in that case, one of the ways of doing that is to use only the youngest, the newest cohort as the denominator. And this is has proven to be a good way of assessing the program coverage over time. We also see now that with increasing numbers of countries reporting registry data, or in other way, cumulative data in the different cohorts, that we have a different way of looking at coverage, very much like we do by 15. We accumulate everything up for a certain cohort over time. Something similar happens when we use registry data. So for some countries, we now move to a way of assessing the program coverage by assessing the coverage by 12 years of age, for example, to see what happened at both 10, 11, 12. So they have a running type of coverage. So this is a slight difference than that we have with childhood vaccines, where you have more of the same approach, same method for each country. The other thing I wanted to focus on is using survey data points. And this is the kind of image that you may be used to seeing when you see the profiles for your countries for various vaccines. And you see that survey data sometimes lead to adjustments in the estimate of the coverage. And here I show you what happened when we've recently incorporated data from surveys, a series of surveys from Mexico. And this, has led to an adjustment. This is very much the same way it's being done for the unique childhood indicators. And this is what we think we'll be doing in the future more and more as we get more survey data points. So it's interesting to know that in the Americas region, countries like Canada, Mexico, and the US all have survey data. So most of the North American countries, survey data are being used, and that increasingly in some of the countries in the South and the middle of America, we also get these data points. So what has happened going to the results in 2025 with the HPV global coverage? There was after several years of very strong progress, there was less progress in the last year. You can see that for the first dose coverage in females, we moved from 32 to 30, from 31 to 33, so a slight increase, and with a slightly steeper increase by the final dose coverage, which is now at 31%. One of the reasons that the final dose HPV coverage in females and both males is converging more and more with the first dose is actually the strong adoption of one dose vaccination for HPV. The way we calculate this is that any country reporting first dose gets the value into HPV1. If you have first dose as the end dose of your series, then the same value gets into HPV-C, into completed doses. And that's the reason why these two values for the global level are starting to converge. We can also see that globally, the coverage in males is still much lower. So when we look at the picture by country, and I have not been able to do an analysis for just the countries from the American region, we can see that the distribution that we've seen in earlier years hasn't changed very much. We still have very high performing countries and low performing countries. The averages, and you can see that in these green lines for 2025 compared to the purple lines that were the averages in 2019, pre-COVID, have still not completely recovered from the pre-COVID levels, particularly in the higher income countries. The lower income countries, as we see below, and where most of the middle income and the lower income countries also from your region are actually doing slightly better. So in your region, we have several countries that perform very well, like Cuba and Brazil, that are in the range close to 80 and higher. And we have some countries particularly from the Caribbean, where such as Suriname and Grenada, that have a very low coverages and are really in the tail end. And there haven't been major changes in these last years. So if we look just at the region, this is from our dashboard, and it gives the overview. We see on the one hand in the orange circle that most countries have moved to a single dose. We see that also most countries have now moved to vaccinate both sexes, and that only 2 countries have not yet introduced. We also see that the coverage is on a positive trend. So this is the population-based coverage in the region. We have thereby corrected for the population size in each of the countries. So region-wise, we're in an upward trend, and the Americas region is one of the high-performing regions in the world. And particularly when we look at the boys coverage, this is much higher than anywhere else in the world. Jan also already showed this figure with the different colors. And when we just focus in on HPV, we see that the 5% remaining this year of those in red who have the so-called introduction gap represent the girls living in the 2 countries that have not yet introduced, Haiti and Venezuela in the region. And so, of course, introduction there is very important. But the other area, the gray area, is those that live in a country where HPV is introduced, but we're not able to reach them. And so this is, as we can say, it's not even the dropout. This is, the green bar is those who have received 1 dose. So the ones we have not been able to reach for HPV tend to be a very high group. And this is, of course, exacerbated by the low coverage in some of the countries. But actually in many countries, we have 20% or more of the girls that are not being reached. So this is indeed where our efforts in the coming years should absolutely be. So finally, also to say that there are products. I already pointed to the HPV dashboard, which is a specific dashboard where you can find all the information on individual countries, and it's also the data is in different data sets that are referred to here. So with that, I want to thank you very much and hand back to Marta, to our chair.
Thank you very much, everyone, colleagues in WHO. Thank you for those interesting presentation. We are at this moment having a small space for question and answers for our colleagues in WHO. If anyone has any question, just please raise your hand or write it in the question and answers. Well, I think everything was very clear. Later, we will share with you the record of the presentation and the slides. So we will share that with you later in the week. Well, so we don't have questions. Thank you very much for everything. A ver, let me see.
No tenemos comentarios en el chat y en las preguntas.
There are no comments in the chat,
Hay una pregunta
but we
de
do
Darwin
have
Luna.
one question from Darwin Luna. Which do you believe are the major challenges faced by the region?
Do you want me to translate the question for you guys? Do you?
No, maybe I can start and Paul will complement. And I don't know if our colleagues from UNICEF want to start. We can also give you the floor first, because this is something which is done by both agencies, and we've already spoken a bit. So please, I'm seeing you here, Eduardo, go.
Gracias,
Thank
Lauren.
you.
Perdóname un segundo.
I apologize. Just give me a moment. Before offering you the floor to respond to that question, we wanted to welcome you It's Dr. Eduardo Celade. He's a senior health advisor at UNICEF. That being said, Eduardo, please go ahead. Thank you very much. Thank you, Marta. And I'll speak in Spanish if everybody can agree to that. We do have interpretation, and I apologize for my late connection today. Before speaking about challenges, as asked by the colleagues, let me first thank PAHO and WHO and all participants today, over 300, on this very important event. And this is what we do every year. We discuss WENIC a little bit. And what I would like to do is, I like seeing that there's interest in this. We look beyond the data, but we want to understand what it means, how we can improve it. And hearing these presentations from WENIC, we see that there is prudent, moderate optimism to be drawn from the presentations, but we must not be complacent. We have moved from 1.4 million of children, and we can see how there is improvement, but there's still much to be done. But we do have concerns. Vaccination is a matter of concern. There are still 1.3 million children who haven't received their measles vaccine. And here we're seeing so many outbreaks in recent years. We're also seeing the issues having to do with inequalities between countries, but also within countries. And linking this to the question, what I'd like to do is focus a little bit on DPT-3 vaccine coverage. Although it has improved a little bit with DPT-1, but with DPT-3, we're less than 83%. So we are improving with first-time children, but we are not improving in the next groups that we reach out. There are over 500,000 children who started their vaccinations, but they didn't complete their 3 doses of DPT. So, answering the questions about challenges, we have a challenge of access, 1 million of children who haven't received any vaccine, but we also have another challenge, and that is continuity, quality, and resilience of primary healthcare services. Quite obviously, we're still missing children between the DPT-1 and DPT-3. Another challenge that I see is measles, how we can achieve these high coverages of 90% to avoid epidemic outbreaks. And we need to look back, and this is something that we've discussed today. In 2015, that is to say 10 years ago, in 6 of the 14 vaccines, the coverage regionally was at least 90%. Now, we don't reach that level at all in any country. So how can we recover that vaccine coverage that we saw pre-COVID? So the final reading and trying to summarize the challenges is that we can see that as a region we can recover. We have the leadership of PAHO, we have UNICEF, subcommitted governments, we have reduced the zero-dose children, we have overcome the DPT-1 levels pre-pandemic, and recovery faces the challenge of inequality, of finalizing the regimes, and the overcoming of gaps. So I'd like to thank everyone, Marta, Marcela, and all the others for entertaining this discussion, because I think it is very timely and very worthwhile. Thank you very much, Eduardo.
No? Okay, well, we will have another presentation ahora, colegas.
So, colleagues, we're going to dive further in depth in the situation in the region. So the next presentation will continue providing us more information to feed into this very interesting conversation we're having today. With that being said, I'd like to offer the floor to Marcela. Thank you. Thank you, Marta. And I thank the speakers for their presentations, which are a true complement to what we're going to now present. Hopefully you can see my screen, but it's not in presentation mode, Marcela. Let me just fix that.
Ahora ya no la vemos.
Sí. ¿Ahora? ¿Ahora?
Can you see my presentation now? No, not yet. Now, yes.
Perfecto. Gracias. Bueno, yo les voy a presentar.
What I'm going to present is the vaccine coverage in the region of the Americas, but based only on administrative official data reported by countries. And contrary to WENIC, that uses different sources, what we're doing in this presentation is only present official data submitted by countries as to their vaccine coverage for 2025. As I was saying, these are official data presented by 34 member states and 10 territories and a US surveys for 2023-2025. We'd like to thank all the countries, something that we always do, for all the support extended to us and the information they share with us using the JRF, from PAHO, WHO, and UNICEF that provides us data as to the situation of vaccination in the countries of the region. And obviously, we suggest you visit the dashboard with the official data from countries. Let us now turn to vaccination coverage. Here you can see the different vaccines that we have looked into. And here we can see BCG vaccines regionally attained 90% in 2024, and we've been able to maintain coverage above 90%. Here there is a drop in hepatitis B of new births, 24 hours. That's the indicator we use. So it fell from 73 to 66%. This is a significant drop. There's a slight drop also in hepatitis B vaccine when considering all data of administered doses with the 24 hours and the tolerance period of countries, which is a little bit more than 24 hours. In some countries, it can be 3, 5, 7 days. So there was an improvement compared to 23, but there was a 1% drop compared to the previous year. Good performance was seen, perhaps not 95%, but we're on the right path. It's with the first doses, or DTP1, in other words. We were already at 90% for 3 years. And last year, we were able to have a 3% jump, reaching 93% of the first dose of DTP. In the case of DTP3, we had been stable at 87%, and then last year we had a slight increase, 1%. So it's now 88%. IPV1 has a similar behavior to DTP1, which this is administered at the same age. So there was an increase from 83 to 93%. With the third doses, polio 3, there was a significant increase, 3 percentage points. With Rota, likewise, we had been maintaining 82, and now we've increased a little bit to 83, but we are still not even close to 90% and even less to 95%, that being the regional target. With SRP1, we have been stable, 87 to 88%, and even 89%, but we have a 1% drop compared to 2024. And we have a group of susceptible population that is unvaccinated, and that is from previous years. As to the second doses of SRP, here again, there was an increase from 80 to 85% in second dose coverage, which is an improvement compared to earlier years going back to 2019 through 2025. But nonetheless, this was not sufficient. We need to reach 95% coverage, and we have a significant gap that needs to be overcome. This simply shows a general panorama of coverage behavior. In red, these are the coverages of less than 80%. And in light green, coverages between 95 up to 100, in some cases even greater than 100. But we see here that vaccines in green, we had a transition moving to 1994 and then less than 90% and sometimes even less than 80%. And we're now on recovery here. And once again, in BCG, we have moved from red to orange, and now we have reached yellow, which is over 90%. But for no vaccine, are we in the range of 95 to 100%? So we have work to be done to continue forging forward, improving coverage to reach the optimum coverage that we established for the region of the Americas. This is the historical trend for the first and the third DTP dose. As Eduardo mentioned, there has been an improvement in recent years, especially post-pandemic. And there was a question earlier to see how the pandemic impacted us. And the pandemic impacted the region and the countries in the region, because here we do see a drop in 2020 and 2021 and efforts carried out by countries in order to recover coverage. However, we have not yet reached the historical figures for the region where we did have coverages equal, the same as or greater than that 90-95% range. So we do have work to be done. We're on the right path, but there is a gap still that needs to be broached. In the first graph, we have a list of countries with vaccination differences. This is DTP3 comparing 2024 and 2025 coverage. There are countries like Bolivia had an increase in their official coverage that is reported through JRF. They had a 23% compared to the previous year. Honduras and Mexico, and Turks and Caicos, Argentina, Panama. So we see how some countries are increasing their coverage compared to previous years. But then there are also drops in coverage. These are negative between 2024 and 2025 in the case of some countries, such as here we have St. Lucia, Suriname, Bermuda, Guatemala, and the color indicates the target population and the range of population. And there are countries such as Venezuela where they had a significant drop in coverage compared to the previous year.
And now we move on to the next slide, and we see the behavior of coverage. You see the blue dot for 2025, and we have the light blue for 2024, and the very light blue is for 2019 to establish the comparison with the pre-pandemic period. And we see that some countries have surpassed the coverage compared to what we had in 2019. We have Guyana, and the difference is quite low because they already had good coverage levels. But here you have, for example, El Salvador that has a better coverage rate than 2019 and 2024. But we also see other countries. We see, for example, Suriname, the coverage in 2025 is slightly below those that they had for 2019 and 2024. And here we also see a significant issue that has also been mentioned, which is the dropout rates, or that population that begins a vaccination schedule, but that doesn't complete the schedule. And so we can see here that we have 19 countries with a dropout rate above 5%. So this is a population with the dropout rates, and this is very important for the immunization program because this is population that had access to vaccination, to the vaccination schedule with DTP1, but they have not completed the vaccination schedule. We see countries like Bermuda, Panama, Bahamas, Venezuela, Brazil, that have a dropout rate that is significantly high, with a population that did have access to the immunization program. And on the other hand, we still see programs with a negative dropout rate. This means that they have a more DTP3 reported than DTP1, and there could be several reasons for this. It might have to do with the quality of the data, or we have to really delve into this to find out what's happening with this. And in order to complete the analysis for the third dose of DTP3, in the brown line, we see the regional coverage of immunization of DTP3, that in 2025 was at 80% at a regional level, 88% rather. And we see that since at the regional coverage, it has a weighted average based on the population, we see in colors those countries that belong to the first quintile of a greater population in the region. So in a way, these countries push the vaccination upward or downward, depending on the results that we have. We see here Venezuela, for example, that had a low coverage and that in a way drags the regional vaccination coverage in a downward trend. But we see countries such as the US and Peru that have vaccination that improves the vaccination coverage. Another important aspect in here is to highlight the fact that most of the countries is above the regional coverage. So that is also significant because all countries contribute to the regional coverage. And understanding these analyses, we can see the behavior of the MMR1 and 2, one in blue and 2 in orange, and we see the impact of the pandemic that started bringing down the vaccine coverage, and countries have made an effort in order to raise the vaccination coverage. And the same thing here, we see countries such as Bolivia, Honduras, Mexico, the British Virgin Islands, Antigua and Barbuda, Belize have increased that SRP1 coverage when compared to 2024. But we also see significant drops in vaccination coverage rates that affect the regional vaccination with the first dose of SRP1, as we know it in Spanish, or MMR1. And the same thing with the dropout rate. With the dropout rate, we do have this task pending between 1 and 2, where we see high dropout rates. We see the spectrum of coverage and of a dropout that is much higher. In Argentina, 34% of children that had access to the first dose of MMR1, but that have not completed their schedule with the second dose. Panama, Bahamas, Venezuela, and Haiti. So it is important to give this sense of following up these vaccination schedules and to be able to reduce these dropout rates of these two vaccines, SRP1 or MMR1 and MMR2. And the same thing here with the regional coverages of SRP1. And we see how the countries or the spread that we have in immunization coverage or vaccination coverage in these countries. And some countries have a population weight that is much higher, how they can improve the coverage. Here we see the case of Brazil, for example, that it raises the regional vaccination coverage, and how we also have some countries that start pushing it downward. We wanted to carry out this analysis for newborns, hepatitis B, because we see that there's an issue in reporting the information. There are countries that have information systems where they can report the vaccination coverage for hepatitis B for newborns at 24 hours, and others that don't. So this is an important point, and we see here that the vaccination coverage dropped from 73% to 66% with the spread that we have in the countries. And if we take a look at the coverage for all the dose administered, we can see that it improves the vaccination coverage. And it is important to see that most of the countries are above the regional coverage. And there are some countries, for example, in this case in Mexico, that have a significant weight in the region that have the lowest coverage for hepatitis B. Some other indicators, as we mentioned, in the regions, we see a drop in the number of zero-dose children. To be positive, it is closer to 900,000 children. And so it is important here because we have 900,000 children that have received no vaccine in the DPT schedule. So it is very important to work in completing and bringing these children, completing the schedule, and also to understand the opportunity of vaccination so as not to run any risks with this population. And we see the under-vaccinated, which are those children that have not had any vaccination schedule or that did have access to it but have not completed the schedule. We also see that there's a drop compared to 2021. But we still have 1,600,000 children that still have an incomplete immunization schedule or are unvaccinated. Another important issue is the overlap in coverage that is administered at the same age. We see what's happening. The child goes and they're given a vaccine at the same age. And we see that in this case, for example, we see more children that were given DPT-3 and not polio-3 that's given at the same age. So we have to see what is happening. Are we running out of vaccines? Is there an issue in terms of the overlapping of vaccines and education for parents and for health workers, etc.? Another very relevant issue is the updated dose we see, or the catch-up doses. We see these as static measures for 1 year, but we know that health workers continue to administer vaccine doses. And we see, for example, the 2023 cohort. If we add the doses administered, those that were given late or catch-up doses, we see how we improve the coverage of that cohort, as in the case of Bermuda or Panama, where we can see that they even go above 95% with a DPT-1. And the same thing here with the third dose of DPT-3 in the case of Paraguay and Venezuela, how the initial coverage is updated and catch up with other doses. But this is important in order to have good data for the coverage and to understand the risk of not complying with that opportunity. Now let us move on to this other one and talk about subnational coverage in the case of DPT-1. Here we see the percentage of municipalities according to range of population, and we see the target population that lives in that municipality. We see that in 2025, 44% of municipalities have coverage rates below 90%. And we're 53% of the target population for DTP1 lives precisely in those municipalities. And the same thing with MMR1, with 37% of the municipalities have coverage rates under 90, below 90. And 51% of the population lives in these municipalities. So it is very important to understand and to see what is happening in our territories. Now we have some general considerations. It is important to achieve and maintain high and homogeneous vaccination coverage to ensure political commitment and governance in order to maintain strengthened immunization programs involving various sectors and partners, to strengthen program planning through tools such as multi-year plans, operational plans, micro planning integrated into primary care services, to identify, vaccinate, and follow up on zero-dose children, but also those with incomplete immunization schedules or under-vaccinated children, to improve the quality and the availability of data, to combat misinformation, and to strengthen confidence in vaccines, to ensure financial sustainability, and last but not least, to strengthen evidence-based decision-making through the evaluation and strengthening of NITACs and the provision of recommendations. And we will leave with you some resources available at PAHO so that you can have the link and you can review this later, and that this might be helpful in establishing the diagnosis of the current status of the immunization program to support the development of plans and studies, etc. I believe that I've already taken a bit more of the time, and you are invited to take a look at the different dashboards that we've worked on, where we have made available all this information so that you can have easy access to these links. Thank you. Thank you very much, Marcela. Very kind of you. And now I would immediately like to go on to the presentation by Dr. Ana Catarina from Brazil. Dr. Ana Catarina, I know that you're here. Yes, I'm here. Please, thank you very much. And you have the floor. First of all, Brazil would like to thank you for the invitation to present the development of vaccine coverage in Brazil and the strategies that the country has been working on. And now let me share the presentation. Are you sharing the presentation? Could you pull it in presentation mode, please? We don't see it in full presentation mode.
A ver, volvamos a
Let me
intentar.
see. Let me try. If not, let me know, and then I can show the presentation. Yes, it's ready. I believe it's good now. Thank you. Now we can see it in presentation mode. And as I was saying, the Brazilian context is monitoring the vaccination in a continental country. Brazil is a country that has a unique health system, SUS. We have over 5,000 municipalities and 27 states, more than 40,000 vaccination sites when we consider public and private rooms, and we have a variety of information systems. So we have the immunization action that are taking place so that these actions will be seen. And for that, we need adequate information systems. All of these are clearly aligned and working together so that the strategies and the improvement of the coverage will be seen. So this was a huge challenge. It's always been a great challenge in Brazil to always have these records managed in the country. We have over 170,000 doses annually, and that the data be comparable throughout the country. And the evolution of the country, the program that was created in 1973, it has a law that was enacted. So this is an institutional policy. We have a national immunization policy. Over the time, we have the expansion, not only the availability of vaccination services, but also the inclusion of new vaccines and the expansion of its vaccine calendar. And with that, the decentralization of actions, strengthening the local level efforts, and thus expanding the protection of the entire population. And in 2026, the program started working with an expanded policy, considering the calendar, the named registration, the analysis of data quality, all the vaccination strategies that were based on micro planning, always thinking about territorial strategies. So we have a vaccination program with integrated immunization management. And obviously, with the development of the program, we have the evolution of vaccination systems. We have the information, named registration, name-based registration. So we see between 1994 and 2021 how we brought together the integrated work that we did with this data. So it's a model that was based on doses. So it is information that is focused on the amount applied. Then we have a nominal registration. That is to say, it is a registration with the name of the individual and the national integration of data connected or linked across systems and regions, territories. So we have an information system of the Ministry of Health proper that is integrated with our own systems, and also data that is recorded in private entities, so working with electronic registry. So it is integrated and interoperable electronic registries. So we have greater traceability, more and better information, and better decision making. And obviously, nowadays, an advantage is a data quality from a recording to decision making. When we record this and we record the data for the individual, what we see is that the quality of the data becomes monitoring of great importance. From a recording the information, the value of the data. So we see the quality of the data, we have integration of information systems, so we have the opportunity of the data, and also the consistency of the quality, that we have analysis of indicators in transforming the information, the use of data for decision making. That is to say, the use of the data for decision making. So we take the information, then the qualified data, then the evidence, and the decision, which is the best strategy to be executed. So between the quality of the data, it is not isolated, but it goes through our entire flow that you can see here. We have today the work that we do. We work with the numerator by dose type, and the denominator is estimated based on the number of live births. This is a guiding document that we use in Brazil. And then we have the initiatives that were taken in order to recover the vaccine coverage. So to transform this information, the investment in improving and structuring the quality of the information, and to follow this with the evolution and the development of the program based on micro planning strategy. So Brazil has been working on micro planning since 1973, based on the Pan American Health Organization since 2023, and the technical standards on micro planning, adapting the reality in Brazil. In 2023, we implemented this, and we worked on this structuring based on federal units such as the states. And in 2024 and 2025, we worked on specific strategies such as the yellow fever and the measles. And we rated the methodology as we moved forward in the training and the work that we did with the municipalities. So we've done some improvement of the monitoring and the technology based on the reality that we encountered in the territory. In 24 and 25, Many a times we had the federal entities, sometimes we had the municipalities, and the evaluation of the program, and then the arrival in the territory of the Ministry of Health with the support of the state and the different federal entities and the municipality, and that made it much more effective. We had to train the municipal teams and also thinking about these services, leading us to better results. And in 2026, we started working with strategic municipalities. We began in 2025, but we consolidated the method for 2026, and we started working with the municipalities. And a great challenge over these years was obviously attaining sustainability of the process on microplanning and the scaling up of a multiplication within the country. So in 2026, Brazil is working with a strategic focus in improving information systems, the methodology of microplanning in the immunization information system. It goes into health. But in the meantime, in Brazil, we need to adapt our activities to the needs of the municipalities, bearing in mind the complexity of the country and the diversity of systems that we had in 2023. And with this, we identified the opportunity of rating the system, the use of data, timely, reliable data recorded. And with this, we stratified municipalities that we called EVAC. This is a definition of the Minister of Health himself, because these are municipalities that have a real coverage in the country and that have an impact. These are municipalities that reduce the coverage in the federal units, and that includes the total coverage. We use the pentavalent coverage. That was under 80%, and municipalities with more than 189,000 inhabitants. And obviously, municipalities that warned us so that we would pay attention to epidemiological risk, the inclusion of the risk of measles reintroduction, prioritization of areas of low vaccination coverage, and the proposal of standardizing vaccination days. So these are municipalities. We have over 5,000 municipalities in Brazil with this epidemiological stratification, with the information and access system. We identified 45 with the highest potential of having an impact in our recovery for improving of this coverage in our country. And obviously, in one first attempt, we had to assess the quality of the data, the identification of the indicator, and with that, within those 45 municipalities, 19 of them were concentrated on access. So the target was to organize vaccination. 7 municipalities with the records. We had the dose applied that were recorded in these slates, and then to recover the doses. And in 17 municipalities where we had problems with the system. So we concentrated on the integration and the quality of the registration. And so currently, to identify what the real problem is in each one made it easier for the microplanning offices and giving consent for the future stages to conduct the monitoring. And so we better directed the training as well as the monitoring. And what are the solutions for these municipalities to improve their coverage rates? And here I move on to the microplanning. As I said, out of the 45 municipalities, 15 that participated, we had offices. These are municipalities where we worked on monitoring, and 30 municipalities that participated in this office. During one semester, we will work on the monitoring based on the action plans that they presented and the actions that they undertook to follow in order to improve national coverage rates. Today, the overall vaccination coverage in the country, we do have an improvement in vaccination coverage, but most do not reach the best coverage level of 90%. We have BCG, the MMR, the first dose, DTP. So we see an increase in the improvement of these coverage rates. So we have the MMR that has a good rate. We had a low rate in 2022 of 50%, and we see an increase of 35%. in this vaccine. It didn't reach the optimum level, but it did show significant progress, over 35% above the coverage that we had of 50%. And several vaccines that we have where progress has been made. The coverage that has the lowest progress is the problem of a supply. Sometimes it is a vaccine that already had improvement in the coverage. The level is lower, but we already have an adjustment in the improvement of this increase, and also general vaccines like everything else. We have the chickenpox levels that you can see. And here we have the general situation, the overall vaccination coverage. We have an improvement in the coverage. And so if it doesn't reach the ideal level, the coverage will always continue to grow. So this is what we've done and what we've worked on in Brazil. It did not reach the best level, but we always wish to maintain this coverage by moving forward. In 22, HPV reached 72%. In 25, we already have 86. And we have children, 45%. We already have 74. Then the other one, we had 45. Now we have 76. So we should always maintain this because there comes a time which, in fact, we're going to reach the ideal coverage, and the goal is established and adapted and ensures the protection of this eligible population. And this is the general situation of the coverage in the country. It is the overall coverage status. So we have data from 22 to 26, 25, 24. These are data that are still being adjusted. We see 24, but the progress that we made when we consider 22 to 24 and then to 25 is that we have migration in the municipalities that has a less than 20% in coverage, a base coverage of 52%, and these municipalities migrate with a coverage above 80. So in fact, it didn't reach 95, but it did have significant progress, and this is what we need to maintain within the country. The northern region, which is the Amazon region, is a region where we had serious difficulties, not only in vaccinating, but in providing access, but also difficulties in registration, and that has been improving over time, and the work that we do together with the indigenous Ministry of Health. And this is for the other vaccines, so the pneumococcal, the triple vaccine, in polio vaccine. And in Brazil, here we have some time, even at the country with absolute number of zero dose children. We had a significant progress, as we see with the zero dose children. We reduced the number of children, over 2.5 million children that we have in Brazil. We brought it down to 50,000 children. Obviously, this is an indicator that alerts, and that is an indicator on access, a child that did not have access to services, not only in immunization, but in other areas of their health. So here we're reducing that number. So work has been done in micro planning and mobilization on this. And then regarding knowledge, all these strategies that are currently carried out, they're all based on micro planning. And here we have our knowledge generated by Brazil in vaccine coverage. We are improving this, and in the future, we will have cohorts for children under 5, and also all the vaccines for teenagers, addressing the idea that in the future, like everything else, we follow the life cycle, following the national calendar of vaccination. And here we have the series that we have on YouTube on micro planning. We hold in-person training courses, but we also have training with a format online for those that do not have access.
These are all based on micro planning. We have 5 documents already published, some in the international and some in national publications, and this has an impact on coverage and the evolution also of the methodology we have developed in Brazil, and that we change and improve every year, always based on territorial needs. The main challenge is to recover coverage. To recover, we need more than monitoring indicators, but also qualification of data, integration of information, and use of data for decision-making throughout the territory. There are inequalities also, access barriers, and prioritization of population. Plus, in management, there's a need for capacity of local planning, organize the response, and adapt to our realities. In communication, there's a perception of risk and trust, disinformation, and adequate communication is needed. Sustainability, we need to continue actions and monitoring. So identifying areas with low coverage is only the first step. We need to understand the causes and organize a territorial response. That is one of our greatest challenges. Lessons learned in implementing initiatives. We need to work with knowledge, reflect the reality of the country together with micro-planning actions. There needs to be monitoring with precise data. We need to prioritize planning and replanning actions. For data, we need to have qualified records and we need to qualify the response levels. Think of the territories as well as national scopes, and we need to translate matters into different regional realities. Strategies, there are many different approaches. There is a strategy for vaccination that needs integrated actions. Actions for recovery depends on continued coordination between different management levels, whether it's national, state, municipal, even down to local, and to recover those coverages and then maintain them. This sustainability requires to have monitoring in the three levels of monitoring in the health systems in Brazil. And they also need to look at routine services. Then we move from territorial data. There's a strength in coverage. There's a program that's 53 years old and has the major objective of responding to the population's needs and to improve based on the populations. We are working now with priority municipalities. These are described as anchor municipalities. So we need to work on processes and of the further services in order to provide immunization for all at the same time. But we always need to work in the priority municipalities using methodologies to identify them with qualified information that is well organized to identify their problems and main causes. Territorial actions, there need to be strategies based on needs and maintain, understand, organize, act, and support this vaccination. Thank you very much for your attention. Thank you so much, Dr. Ana Catarina, and thank you for sharing with us the experience of this enormous country and that increase in coverage. I do believe you have covered many of the strategies that ought to be borne in mind in order to increase coverage. So thank you for that. Let me briefly offer the floor to Dr. Hugo Curizat, who will be presenting the experience in Paraguay to strengthen their information systems and use of data for action. Dr. Curizat, you have the floor. We can see your screen, but it's not in presentation mode. Thank you. Good morning to all delegations and authorities of the Americas. It is an honor for Paraguay to share with you today our experience at this virtual seminar on vaccination coverage for the year 2025. As this graph shows, following the pandemic, and we've already seen this with previous presentations, the years 2020 and 2021, our vaccination levels dropped significantly. especially in 2022. If we look, for instance, as SRP1 in our country, it fell to 54% and SRP2 to 53%. This is an alarming situation. It demanded immediate action. And in the past 3 years, we have done this thanks to joint efforts and a modernization process for our strategies. And this has resulted in sustained recovery. For the year end 2025, we reached a 97% coverage for BCG, and polio 1, 78%, and DPT 1, 97%, and SRP 1 reached 93%. But as you can also see, the general coverage is still insufficient if we don't consider the children who are left out. So sometimes we have a false feeling of security. The true indicator for continuity of regimes is the dropout rate. Marcela presented that behavior that was faced by all countries with the trace biologicals. So there is a difference in behavior in our countries in recent years when it comes to DPT-1 and DPT-3. We even reduced the dropout to 2% in 2024. And after that, there was a slight increase in 2025 when it comes to the first dose or the 2 doses of SRP1 and 2. The dropout had reached 31% in 2023. By 2024, it was 23%, and in 2025, we only had 6%. This is thanks to implementation of an active nominal follow-up strategy. We took advantage of data available to us in the electronic immunization registries so that at the local level they have access to that information and are able to follow up the children that are part of the system now. Here we see that to overcome the dropout rates and have an opportunity, what we did was to digitalize all our data. I think all countries have, to a certain extent, moved forward with the electronic immunization registries. We had 4 linked strategies functioning as a single cogwheel. First, we consolidated the nominal records for individual tracing. Second, we developed an operational analytical responding to local needs for the entity providing vaccines. Third, we implemented the simultaneous monitoring to eliminate the missed opportunities at the point of care where vaccines are administered. And the fourth point was what we called a strategy to contact patients. We identify the children that have been left out, and we're able to use their names for that. This infrastructure that supports the country's responses has been evolving over the last 17 years through our institutions. In 2005, we had a system called EPI Visual that used electronic data. By 2011, a leap was taken using web platforms. By 2018, in collaboration with the Ministry of Technology and Information, we developed what was known as PAHO. And the pandemic really accelerated the process. In 2021, we implemented the electronic vaccination card. And lastly, in 2022, in January, a decision was made to have the electronic immunization Immunization Registry as the only reporting system nationally. And this legal and technological transition makes it possible for us to today say that the EIR is a consolidated reality for the entire country. The system provides absolute traceability of information, so we know precisely who received what doses, which vaccine lot or batch, where was it administered, in what territory, on what date was the dose administered. This level of detail encompasses over 6 million individuals in our country. We have their names in our database with over 35 million accumulated doses recorded historically through a national network of vaccine centers. It can either be public, private, or social security. The EIR in Paraguay operates as an ecosystem that is interconnected. We try to provide information to the citizen on the one hand, on the other hand, a lot of information for vaccination centers to be managed and make the decisions. And what is important is to manage the biological. So when a child comes to one of these health centers or vaccination centers, the vaccinator immediately accesses the electronic card and records or registers the vaccination on the system. This also feeds back to the biological stock that they have and discounts or deducts the doses that have been used from the stock in their refrigerator. This simultaneously feeds into our dashboards for national decision making. It's all from a single official data source that is reliable, and what's so important is that it's in real time. There is one question: how do we translate this tremendous database in different operating aspects that each vaccinator is interested? An analytical matrix with 4 standard reports. First, we have the report on residence telling us where our patients live so that the territorial planning can become effective. The report of occurrence to assess the productivity and performance of each health facility. The follow-up report calculates the dropout rate and issues alerts as to missed opportunities occurring in the vaccination centers. And lastly, a nominal report that provides a list of the names, full names of the children, and even most important, their phone call, which is very important and mandatory information to be provided as to users. This is to ensure we can have a nominal follow-up, very specific of cases of children that have an incomplete vaccination schedule. So this is information for action as far as we're concerned. Here we can see a tool, perhaps one of the most powerful tools in the EIR system. This is monitoring simultaneous action in real time. We have a fake name here, Junior Medina. He goes to the hospital for a routine control consultation. By entering Junior's document number, we have the option to look him up also through the mother's document. When a child's name is recorded in the EIR, it is linked to the mother's name also, because very frequently there's a change of name or perhaps a change in identity number, or doesn't even have the document yet. So it's easier to be able to locate the child also through the mother's name so as to be able to document the vaccination schedule. The staff sees immediately a visual red light. This is a check light that we can see. It's in green to show if they have received hepatitis, or there might be an empty area if a vaccine hasn't been administered. So that way, the practitioner can continue with the required regime, and you don't need to look for written or imprinted or handwritten forms. What we want is to have a tool that's useful for all practitioners. Once we have the nominal data and knowing exactly who is missing a vaccine, and this is an example that we use in the case of measles when we had the outbreak last year. The registry in our country generated the list of children that hadn't yet been vaccinated or that were behind schedule. This helps us to send messages, individualized messages using the WhatsApp business platform. We have a single phone number, an institutional phone number, and through this phone number we can send these reminders to parents, reminding them that their child, indicating the name, is still missing a certain vaccine, and they can go to the center where the child is registered, or we even send them a link of other links that are close by to them. So this is information that is piloted or initiated where there was the measles outbreak, but now we're also applying it to the RSV vaccinations. This shows then specific examples. We sent over 26,000 messages. We're talking about institutional messages based on these electronic name lists, and out of the more than 26,000 messages sent, we see that not all were delivered because not all have access to WhatsApp. So what's important is the quality of data received at the vaccination centers as to the phone number of parents. But nonetheless, over 19,000, practically 20,000 messages were successfully delivered, and more than practically 11,000 children came back to receive their RSV vaccine. So 1 out of every 2 messages did generate a vaccinal response, and this became 1 more child protected. We want to scale this up for other trace vaccinations. This was a successful experience for us because frequently parents, it's not that they reject vaccinations, it's just they need a reminder as to what vaccination their child is missing, where can they go for it. We even generate automatic responses through a Gemini bot because there was a lot of interaction from parents. So in order to improve the experience, we developed this bot so that every message are responded as soon as possible, and that way generate confidence or loyalty regarding the vaccination process. So just as we see in the private sector users, we also need to protect this client. And we believe that is the kind of care we need to provide to each mother, each child concerning vaccines, so that their experience is positive and they will come back for the future doses. The main challenges as a country, we want to be very honest talking about this. We need perhaps to develop more technology, more software, and that might be the easiest aspect. But the challenge is to ensure the sustainability and the quality of data in the territorial gaps we face when it comes to connectivity and resources and capabilities for analysis that varies within each territory, each department, each municipality, as well as the ability to contact. So consult the mother at each visit to see if that is the same phone number, if they've changed address, or whatever other changes they've had. We need to continue working on this. And the practitioner needs to understand that these digital tools that we are developing are useful and truly afford greater empowerment to the parents. Lessons learned. Paraguay's lessons can be summarized in three important. One, to have the names is not sufficient. To accumulate thousands of millions of names on a server are no use if you don't have automatic alerts or lists for individual catch-up doses. Two, we need to close the circuit. Detection, geographic location, contactability via WhatsApp, physical vaccination, and final verification in the registry of each country needs to work as an unbreakable cogwheel. And then it needs to be managed locally. Dashboards are useful only if the practitioner or the center or the supervisor at that center can turn this into micro plans that are specific to their area in order to reach all of the children in their community. So that's what I wanted to share with you today. Thank you very much for offering me this opportunity, for sharing with you the Paraguayan experience. Thank you, Dr. Luis. Thank you also, Dr. Ana Catarina. Thank you very much for sharing with us these experiences. I think that between the two, you have summarized very clearly some of the chief strategies to improve coverage. I was delighted with what you said, Luis, and that Dr. Ana Catarina also showed clearly that digitalizing isn't the only response. To have a nominal list isn't the only response. It is a nominal record that is used to take action, but is useful to whoever administers the vaccine. And if the practitioner uses it, then it will be useful to us also. So this message that you have shared with us as to the importance of information systems that facilitate decision-making at the local level is one of many that you've mentioned. Micro-planning, for instance, and there were questions in the chat as to which strategies can reduce measles cases. And we believe that micro-planning, when it's coordinated and well organized, is helpful. And this was showed very clearly by Brazil, how through micro-planning, they were able to once again recover coverage. Thank you also very much for all the questions in the chat. Because of time constraints, I'm afraid we won't be able to entertain more of these questions live during the webinar. But please send us all of your questions, because we will send them to those responsible to help answer all those questions. HPV has been another topic addressed in the chat, and the importance of continuing to improve coverage. The issue of having a single dose has been a great facilitator. It has allowed us to improve coverage. And WHO, Paul, and we here are totally willing to help you in whatever you feel is necessary. So thank you so much. I think we have had an extremely good panel. As I said, unfortunately, we're not going to be able to have an opportunity for discussion because of time constraints, but I wanted to give the floor once again to Dr. Rasuri, manager, to close the webinar. We've had over 370 people that have remained connected right through to the end of this webinar. Thank you very much for joining us. Thank you, Marta. You stole words for me. It's impressive to see so many people connected, and this truly reflects the importance of immunization in the region. A team of people committed throughout the region and the years in different circumstances and with different challenges. They're always there. I think you have made an excellent summary of what we have discussed today. And as Eduardo said a few minutes ago, there are truly some successes, but there are also major challenges that are several years old when it comes to not managing to recover coverage levels, and also issues such as measles affecting so many countries right now and new outbreaks. So in addition to the routine activities of immunization programs, many countries need to also earmark some resources to tackle these other problems. So it requires more intensity in our work. It's also important to mention that in many cases these are national figures, and in many cases they also hide realities of deep inequity and heterogeneity within countries. And this is one of the most important challenges we face when it comes to immunization, not only to achieve acceptable coverage at the national scale, but also ensure that these pockets of susceptible populations don't remain excluded. We don't have examples of these under-vaccinated populations, but that is precisely where the immunopreventable or vaccine-preventable diseases appear, such as pertussis and other diseases in recent years. So let me close now by thanking the colleagues who made presentations. Thank you very much to the colleagues from Paraguay and Brazil who have raised very important forward-looking points. The importance of the tools that we have in order to reach the entire under-vaccinated population, and especially the importance of information systems and their use. This is critical for these analyses to be able to act with evidence to tackle all the gaps. Thank you very much for your presence and for having organized this webinar. And we will stay in touch with all of you in your countries through the focal points and other institutions. Thank you very much. There's one last thing that Ana Catarina mentioned, and I think that we all need to be ready to celebrate. Next year, the regional immunization program will be 50 years old, and we'll have the 25th week of vaccination in the Americas. So let us work to increase coverage as we celebrate the 50 years of this program. So much love, effort, and work. So let us all feel very encouraged, and thank you all so much for your participation. Goodbye to you all. And it's still good morning for us, at least here in Washington.
Hey, Lord. Thank you. Paul, thank you.